Good afternoon. My name is Amir Al-Hajimisa with ESET Patel. Thank you for joining this webinar titled A Side-by-Side Comparison of eCQM Logic Expression Using Clinical Quality Language versus the Quality Data Model for Eligible Hospitals and Critical Access Hospitals, or CAHs. Today's session will be presented by Shanna Hartman from CMS and Bryn Rhodes from ESET Incorporated. Just a few administrative notes. Today's meeting is being recorded. Attendees are muted. At the end of the session, a feedback form will appear. Please take a few minutes and tell us how we did. We appreciate your feedback. Throughout the session, you can use the question and answer feature of WebEx to submit questions. A question and answer period will occur at the end of the session. I'd like to now turn it over to Shanna Hartman from CMS. Thank you.
Thanks, Amira, and welcome everyone. Thanks for joining us for our CQL webinar for eligible hospitals and critical access hospitals. After I provide a brief overview of clinical quality language, or CQL, I'll be passing the presentation off to Bryn Rhodes, who will be giving a walkthrough of two measures using the CQL expressions and comparing the same measure logic using QDM. The two measures we're going to tour today are CMS 104-2, discharged on antithrombotic therapy, and CMS 55, ED1, median time from ED arrival to ED departure for admitted ED patients. Next slide, please. CQL is a Health Level 7 or HL7 international standard and aims to unify the expression of logic for electronic clinical quality measures, eCQMs, and clinical decision support, CDS. CQL provides the ability to better express logic defining measure populations to improve the accuracy and clarity of eCQMs. Several benefits of CQL are listed below. Improved expressivity, more precise and unambiguous, can share logic between measures, can share logic with decision support, can be used with multiple information data models, example, the Quality Data Model, QDM, and Fast Healthcare Interoperability Resources, FHIR, and simplifies calculation engine implementation. Next slide, please. As of November 2017, following more than 1 year of testing and input from the vendor and implementer communities, eCQMs in CMS quality programs will be transitioned to use the CQL standard for logic expression. The transition to reporting CQL-based measures will begin with the calendar year, CY 2019 reporting period for eligible hospitals and critical access hospitals, and calendar year 2019 performance period for eligible professionals and eligible clinicians participating in the following programs: the Hospital Inpatient Quality Reporting, or IQR program, the Medicare Electronic Health Record Incentive Program for eligible hospitals and critical access hospitals, the Medicaid EHR Incentive Program for eligible professionals, eligible hospitals, and critical access hospitals, as well as the Quality Payment Program, the Merit-Based Incentive Payment System, MIPS, and alternative payment models. To support this transition, CMS will publish CQL-based eCQMs in spring 2018. Next slide, please. This illustration is one of the ways we represent the evolution of the current standards using and creating the electronic specifications for eCQMs. On the left is the Health Quality Measures Format, HQMF, which is the basic electronic specification for the measure. The Quality Data Model, QDM, provides information to help finalize the HQMF and is divided into two parts, the data model and the logic. Now that we're moving to CQL, the HQMF will continue to provide the metadata and population structure, and the QDM will still provide the data model, but CQL will now represent the logic used in the HQMF, depicted on the picture to the right. Next slide, please. And here is a general timeline that CMS and our stakeholders are looking at through 2020. During this time, we will be creating eCQMs with CQL and have an expanded testing and development process of CQL and tools. As part of the education and outreach about CQL, we want to engage you all about this standard as we continue to incorporate the standard into the measures. Thank you, and now I will pass this on to Bryn to continue the presentation and provide a more in-depth review.
Thanks, Shanna. My name is Bryn Rhodes. Thank you for coming out. First question that we like to start with today is, what is CQL? We're going to start to answer that question from the perspective of quality measure. So if you look at the health quality measures form, normative specification, which is the specification that we currently use to distribute electronic clinical quality measures. Quality measure is a quantitative tool to assess performance related to a specific clinical process or outcome. So there are lots of different kinds of quality measures, and not all of them are electronic. Our goal is to provide specifications that enable the electronic representation of those quality measures. Different types of quality measures, patient-reported outcomes, structure measures, all of those are potential quality measures, and within the programs that we're looking at here, we specify patient quality measures for and with the goal of enabling the measure to be evaluated as automatically as possible. So by digitizing the measure, we want to enable systems to ingest that definition so they can perform the calculation as much as possible by the system. So to look at how we do that, we'll start with looking at the draft for CMS 104, the description. So ischemic stroke patients prescribed or continuing to take antithrombotic therapy at hospital discharge. So that's a lot of information in a very short description. So there are a lot of details to be worked out and about what that actually means and how you would actually go about measuring, especially if we want to formalize it enough that a system can understand and evaluate what that means. So to build the electronic representation, we separate the information about this measure into three different categories. Metadata is the questions about that description, so who said it, when did they say it, what evidence supports it, how do I go about actually using it. Those are metadata questions. And then there are questions about the content of the description. What does it actually mean? So what kinds of things does it talk about? What do those things look like? What kinds of properties do they have? What are the relationships between the things that we've talked about? And what are the criteria that apply to them? So what they look like and what kinds of properties they have is the data model, the information model about what's the domain that we're describing. And then what are the relationships between them and what criteria apply to them is the logic. So these are the three kind of categories of information that we are looking at for electronic representation. So within eCQM representation, we take those three categories of information. And this depiction shows for the current specifications for HQMF and QDM through calendar year 2018, we use HQMF to represent the metadata, and we use the quality data model to represent both the data model and the logic, so the things that we're talking about as well as how they relate to each other. But with the new specifications, what we've done is evolve that logic portion of quality data model into its own specification called clinical quality language. So with the new specifications, we still use HQMF to talk about the metadata. We still use quality data model to talk about the data involved. But now we use clinical quality language to describe the relationships and the criteria. Throughout this presentation, we'll use the term current specifications to talk about HQMF R2.1 and QDM 4.3, and the term new specifications, or CQL-based, to refer to the updated specifications, so the HQMF normative release 1, the CQL STU release 2, and the QDM 5.3. So speaking of the data model, we use QDM as a conceptual data model. Provides a way to formally specify clinical statements. So we start with categories of statements. So patient had a laboratory test or a diagnosis. And then we add context to say things like laboratory test was performed or laboratory test was ordered. We take to the next level of detail by adding terminology. We say what kind of laboratory test was performed. We do this by binding to existing terminology, so LOINC, SNOMED, ARCS norm. And then for a fully specified data element, we also talk about the properties of attributes. So for laboratory tests performed, you would have results. For encounters performed, you'd have the location arrival time. So those are some examples. We'll talk more about the terminology aspect later in the presentation. This is an example then of encounter performed. You should be generally familiar with this. That's the definition from the quality data model specification. This is the 5.3 version of encounter performed. So you'll notice some differences. Relevant period, for example, replaces the admission time and discharge time attributes. And you'll see that kind of change throughout QDM. Relevant period is an interval, meaning it has a start and an end. And so because CQL now allows you to operate on intervals, we've used that interval to model properties within QDM so that the expressions within CQL can be represented more succinctly. You'll also notice things like diagnoses. This is a plural attribute, meaning a single encounter can have multiple diagnoses. You also have an ID attribute, so you can actually talk about instances of data elements, and a code attribute, so you can talk about the terminology, in particular with the ability to reference direct codes within a terminology. So for the logic component, with the current specifications, as we said, we use QDM to represent both the model and the logic. We still reference terminologies. In the new specifications, though, we create a separate spec for the logic, which allows us to evolve the model independently of the logic. For example, we can introduce new operations into the logic without having to change the QDM. And we can change QDM without having to change the logic specification. In addition, within the logic, we can reference terminologies and the model, but those are kept separate as well. So then what is CQL? It's a standard language for expressing clinical knowledge that is readable. It's intended to be something that domain experts can look at and understand what criteria are being represented. It's shareable, meaning that we can distribute it electronically from machine to machine. And it's computable, meaning that it has enough semantics that we can describe all of the types of measures that we want to perform and do so in a way that can be understood by machines to perform the computation. So note that we've described this from the perspective of quality measurement, but this is also equally applicable to the domain of decision support, which is important to enable the ability to share logic between a measure definition and a decision support rule. So we'll start now with the measure tours. So these will be side-by-side reviews of the current specification using QDM 4.3 and the new eCQM specification using QDM 5.3 and CQL. As Shannon mentioned, we'll look at two measures, CMS 104, discharge on antithrombotics, CMS 55, median ED arrival to departure. I'll just note these are draft eCQM specifications. They're not intended for submission of 2017 or 2018. The updated eCQM information for actual performance reporting is available on the eCQI for Resource Center website. All right, so CMS 104. So we'll start by looking at the actual measure package. So if you've ever cracked open the measure and looked at the actual files within the package, the QDM-based measures have an HTML file. That's the human readable on the web page that you typically look at to get an overview of the entire measure. The .xml, which is the electronic representation, that's the HQMF document that contains all the information for a machine readable. And then simple XML is a simplified rendering of that same logic information. With the CQL based, you'll see the same HTML. There will still be an HTML that's human readable. We'll look at some examples of those. The eCQM XML is the HQMF, so that's still present. But now it references the CQL, which is a library containing the expressions that the measure uses, and the ELM, expression logical model, which is the machine readable. So this is the analog of the simple XML, and this we produce in both XML and JSON formats. And I'll just note that these file naming conventions, those are still being finalized. Those will be posted to the UC Resource Center once they're available. So these will be in the package. Then the file names might be a little different. Note also that these are these represent one QQL library. For measures that use multiple libraries, there will be these files for each library. So that's the measure package. The measure metadata, this is just a snippet of the measures HTML human readable. And for the metadata components, there's very little difference. This should be very, very familiar. All the same copyright and disclaimer, usage, definitions, all of those kinds of things are still available. So looking at the measure contents, for QDM-based, we have these sections: population criteria, QDM variables, and so on. With CQL-based, we still have the population criteria. Data criteria has become definitions. These are all the definitions that are used throughout the measure. Then we have functions. The measure authors can introduce functions to perform calculations. Those will be available in that functions section. There's a new terminology section that lists all of the value sets and direct reference codes that are used throughout the measure. And then the data criteria, supplemental data elements, and risk adjustment variable sections are the same in terms of being present. Data criteria is largely the same, and we'll look at that a little bit later. And supplemental data elements are just a little bit different. We'll look at those as well. So this is the human readable for the population criteria section. So you see we have all the same population criteria, all the same population types, initial populations here. And depending on the measure scoring, the populations, the same sets of populations will be available. There are a few new features, different formatting. There are some you can expand and collapse if you want to navigate around a little bit there. There's also, you'll notice this TJC dot. This is a reference to a library. So we'll look more at that later. But you can also see things like queries. So this is a query here in the Denominator Exclusions with things like aliases and clauses. We'll talk more about what those are. But broadly, you can see the same type of measure structure. So let's dig into that a little bit. This is a view of the declarations for the CQL library for this measure. So this includes the library name and version. This specifies the data model. So we're saying we're going to use QDM in version 5.3. And we include the references to libraries that we'll be using, and then the terminology description. So these are all the value sets that are used by this measure. And then we define patient context, and we'll talk a little bit more about that when we get to the retrieve. So digging into the initial population itself, you'll see we're referencing the function here, the Global Calendar Aging Years Act. That's similar to this age. We're doing comparisons, so greater than or equal to 18, similar to the way QDM did that. But you'll see the initial population is just a reference to this expression, TJC.encounter with principal diagnosis and age. And that expression is then defined as a definition in the definition section of the measure. And it, in turn, references another definition, and we'll dig into that one. But this is saying encounter with principal diagnosis of hemorrhagic or ischemic stroke with a birth date such that that calendar age for that birth date at the start of the relevant period is greater than or equal to 18. So this expression then is returning a list of encounters, not a yes/no. And so that's typical of episode of care or encounter-based measures like this, where the members of the population are actually encounters rather than patients. So what we're counting in the measure is encounters. The description of the measure makes clear that what we're looking for is the antithrombotic therapy at each visit, where as opposed to a patient-based measure that would be looking for a percentage of patients. And one more thing to note on this, and we'll look more at it a little later, but occurrence A of encounter inpatient non-elective is how we represent a specific occurrence within the current QDM-based measures. That's no longer required with CQL. What we do instead is reference the definition. So as we refine the criteria associated with an encounter, we reference that definition in order to apply that. So we don't need specific occurrences in CQL. So we saw the comparison. These are some of the other types of CQL expressions that we see. Can perform logical operations, combining yes/nos. So I can say A and B, or I can perform comparisons between ordered values. And I can perform basic arithmetic just like you'd expect to see in any expression language. Note that this is following standard mathematical precedence, so this will be evaluated as B times C, just like you'd expect. So digging into the non-elective inpatient encounter. So within QDM, this was described as a QDM variable. Within CQL, we define this as the non-elective inpatient encounter definition. You can see the encounter performed here returning encounters that match non-elective inpatient encounter, where the length of stay is less than 120 days, and the relevant period ends during the measurement period. So digging into that retrieve, these are the data elements of the measure. So where the QDM had all the data elements available, and you could use, reference them within the QDM logic, CQL makes the same data elements available, but they're always referenced within the CQL using these square brackets. So whenever you see square brackets, that's a retrieve. The retrieve has two main parts. The first is the type, so in this case, encounter performed. That specifies the type as defined by the data model. And then there's the terminology portion. This can be a value set, a code, or a code system. The value set in this case is non-elective inpatient encounter. So the result is the set of data elements of encounter performed that have a code that matches the terminology that we've provided. So looking back then at non-elective inpatient encounter, this is going to return the set of encounters for this patient. Again, this is evaluating within the patient context that have the length of stay less than 120 days and where the relevant period ends during the measurement period. So sets are combined with intersect and union. You've seen those within QDM. But versus criteria, which are combined with and or. So within CQL, that's an important distinction that we maintain. So this is a query, this whole construct, and we introduce a query with the non-elective encounter alias. That non-elective encounter then is an identifier that allows you to reference the properties of the source of the query. So that's how we're able to get more precise timing, for example, by being able to say which attribute we want to use to define the timing. So filtering with where, digging into that where clause a little bit. Non-elective encounter, again, refers to the source of the query. So this is encounters with code in the appropriate value set. The encounter performed structure defines the attributes. So the fact that we can say relevant period here is because QDM said encounter performed has an attribute of relevant period. We're also referencing the measurement period parameter. So this is provided as part of evaluation to say what the measurement period is. We use that to relate the encounter, and this condition then says that this interval ends during the measurement period interval. CQL supports other interval comparisons. We'll look at a little bit more of those. So digging in, the types of timing relationships, you can compare just two date-time values, just like you'd expect. So you can say, is the author date time of the encounter less than the author date time of the assessment? Or you can compare a date time value with an interval. So you can say, is that author date time during the relevant period? You can compare an interval with a date time. So you can ask if the relevant period includes the author date time. And you can compare two intervals directly. And you'll see all of these types of comparisons. Other interval, other timing and interval types of operations, the full set from QDM. So you can see starts before start, starts same day. You'll see those same type of operations. But we also have timing phrases. So you can say starts 3 days before start, or starts within 3 days of start. And then you can do other interval operators, meets, overlaps, during, so you can compare two intervals directly. And then you can just access the boundaries. So I can say the start of the measurement period. And I can also do membership testing. And note that that's an interval of integers. CQL does support that as well. All right, so going back to the measure, let's look at the denominator. So the result of the expression here is a list of encounters. So again, this is an encounter-based measure. So all of the top-level population criteria will be returning a list of encounters. We're still evaluating your patient context, so the expression is written from the perspective of a single patient. And when an implementation is evaluating the measure, they'll run each patient through each of these different populations, evaluating the patient at a time, conceptually at least. We're using encounter with principal diagnosis of ischemic stroke. So that's the same that we use to define the initial population. This encounter with principal diagnosis and age is the same expression we use to define the initial population. So that's how we're getting the specific occurrences. And again, we see this prefix of TJC, meaning this expression is actually defined within a library. So because it's defined within a library, that allows the definitions to be shared among measures using those libraries. So this particular TJC library defines several expressions that are used not only in this stroke measure, but in other stroke measures that share the same logic. With the QDM-based versions of these measures, that information was duplicated within each measure definition. And note, again, that the measure packages would include artifacts for any libraries they reference. All right, so looking at the denominator exclusions here, we define this in CQL, again using encounter with principal diagnosis of ischemic stroke. So that's how we're getting the specific occurrence. That's the same expression we use to define the denominator. And then we look for encounters in that set that have any of these discharge dispositions or this comfort measures during hospitalization. So we'll dig into that reference next. So in the QDM version of that, the comfort measures during hospitalization, we're looking for encounters performed immediately, emergency department visit encounters performed immediately prior to the encounter inpatient, or that it starts during the encounter inpatient. We see this a lot throughout the hospital measures, where what we're looking for is some event that occurred during the period from emergency department admission through the end of inpatient stay. Within QDM, this is always done in using this pattern of comparing to the emergency department visit and the inpatient encounter. But with the new CQL-based measures, we've defined this hospitalization function, which returns that period from admission to discharge for the entire episode. So using this hospitalization, we can say the intervention comfort measures were either performed or authored during that hospitalization. All right, so digging into the numerator, again, we've used the same encounter with principal diagnosis of ischemic stroke, so that's the denominator expression. And then we say those encounters with an antithrombotic therapy at discharge that was authored during the relevant period of the encounter. And again, the antithrombotic therapy at discharge is then using just a retrieve for medication discharge. You can see that is the same data element that the initial QDM is using. And then lastly, for this measure, we'll look at denominator exceptions. So the exceptions are that they had a medical reason or patient refusal for not performing the medication discharge. So again, we start with the encounter with principal diagnosis of ischemic stroke with antithrombotic not given at discharge. And in this case, we're saying medication not discharged. So you can see this syntax is a little different. For consistency with the positive statements, we use the same value set approach, but we use this prefix of not. So you'll see things like performance or encounter not performed or medication not discharged. And then we use the negation rationale attribute of the medication to limit to the value sets for medical reason and patient refusal. So this is what the not discharged equivalent in CQL looks like there. All right, so looking at the data criteria, within the QDM based, you see all of the same data criteria in the CQL based, except for the attributes. Note that we don't use the attribute data criteria anymore. Those are referenced in the CQL directly and specified. The value sets are specified in the terminology section. Note also that we've included the supplemental data as data criteria. So for the CQL based, there's this terminology section. So all of the value sets, whether they're referenced by an attribute or a data criteria directly, are specified here. It'll also potentially include direct reference codes rather than only value sets. And in that case, you'd see a code. So then supplemental data for the QDM based, it looks a lot like data criteria. And the same is true for the CQL based, except that we've allowed that to be a full expression so that for supplemental data, you can be more flexible in the supplemental data you're collecting. And we use the same approach to risk adjustment variables. So these are now allowed to be expressions just like the criteria, so you can distribute risk adjustment variables as factors, and we can support more flexible supplemental data description. All right, so that was 104. We're going to look at 55 now. So this one is a continuous variable measure. Median time from emergency department admission to time of discharge from the emergency room for patients admitted to the facility from the emergency department. So this is going to calculate an observation for each member of that population, as opposed to a proportion measure that calculates an overall percentage using the sizes of the numerator and the denominator. So the initial population, look at this real quick. The inpatient encounter with encounter performed emergency department visit, such that that emergency department relevant period ends 1 hour or less before the start of the relevant period for the encounter. So this is inpatient stays that have an immediately prior emergency department visit. For the measure observation, within QDM based, there was this date-time diff, and then you would say what attributes that was performed on. In CQL based, we actually have a duration in minutes, so we use duration in minutes of arrival and departure time of the related ED visit for the encounter. And this related ED visit function, we're saying for a given encounter, give me the most recent encounter performed in the emergency department patient visit value set, where the relevant period ends 1 hour or less before or on the start. So this is, given an encounter, going to return the most recent immediately prior emergency department visit. And then we use that to compute the arrival and departure time as an interval, and then we just take the duration in minutes of that interval. And then the fact that it's a median is carried in the HQMF itself. So this measure has stratifiers, and you can see the expression of the stratifiers. Here it's saying encounters with the principal diagnosis of psychiatric or mental health. So this first stratum is saying the encounter that does not have that as a principal diagnosis, and stratum 2 is encounters that have that as a principal diagnosis. And again, the use of occurrence here. This is how we did this in QDM, and where in CQL we just reference inpatient encounter and further restrict it using a query there. All right, so these are some links for available tools and resources. The CQL specification itself is available here. The CQL-based HQMF IG, which is the implementation guide that describes how to use CQL and HQMF, as well as QDM, to express and distribute electronic clinical quality measures. eCQI Resource Center. There's a CQL space. This includes the QDM V53 and V53 annotated specifications. The events in particular are there, and educational resources. There are more tooling resources available here for these links. Formatting and Usage Wiki. There are some Q&As there that are common questions that we've encountered so far. There's a tooling repository, and then, of course, the measure authoring tool and the buying testing tool. And if you have issues, tickets, submit there.